I'm Patrick Kennedy. I'm so honored to join all of you for this important discussion. Obviously, I come to this discussion from the vantage point of having been the author of the Mental Health Parity and Addiction Equity Act, which is seen by many in this field as the kind of modern day Brown v. Board of Education type legislation that really highlights the inequities in mental health care when compared to the rest of healthcare. Parity, of course, means equal, and fighting for the Mental Health Parity and Addiction Equity Act was all about trying to rectify the historic disparity when paying for any type of mental health care or any type of addiction care. Just in short, the Parity Law says inpatient, in-network, outpatient, in-network, inpatient, out-of-network, outpatient, out-of-network, and pharmacy and emergency room benefits. I say that because these are 6 buckets where we have a measurable comparison to the rest of physical health care, both on the quantitative side, which means co-pays, deductibles, premiums, lifetime limits, so that there's no disparities in payment, but also on the non-quantitative side, which means in the quote medical management piece to this. And of course, all of us know that the historic stigma towards mental illness and addiction has made it easy for payers and for the public really to downplay the significance and importance of mental health care in our country, such that we still have a very carved out mental health addiction treatment system that is substandard when compared to the way we reimburse medical and surgical care. So the Parity Law gives us a template to fight for more funding. And the reason we're talking today is that we're obviously faced with this historic crisis of COVID-19, which takes our current epidemic of overdose and suicide and pours gasoline on it, because we know that the economic stresses and the fears and uncertainties that come with pandemic and the social isolation that's called for as a way to minimize the spread of the pandemic, all of those things create a real exacerbated effect of the underlying mental health crisis that's never fully been addressed, such that we really will see an enormous kind of upsurge in care need out there in our country. And of course, the challenge in mental health care has always been matching the enormous demand with the short supply. So if that was already our challenge, imagine how much bigger that challenge will be come the increased demand on our system from those suffering from the after effects of the trauma that comes from such a high unemployment rate, which we know corresponds tragically to increases in suicide ideation as well as statistics of suicide increase. I say all of this as a backdrop because you can't really appreciate the need for why technology is such an important lever in helping us try to take a small supply and really leveraging that to meet a greater need while we build the supply. And ultimately what we need to do is build a systemic supply of care providers. But until we do that, we have to maximize, if you will, the efficiency of our current supply and at all levels of the professional service line, from psychiatrists and all that's entailed in psychopharmacology to counselors, peer support, social workers, case managers, psychologists. These are all levels in the recovery and mental health and addiction treatment spectrum that need to be really blown out through the use of tele-mental health. Not just telepsychiatry, but everything that can help people who have a chronic illness of depression, of anxiety, of addiction, of all kinds and help them have that constant monitoring that which we all know is so crucial to both compliance with evidence-based practices, including all forms of cognitive behavioral therapy, but also which lends itself very appropriately to how do we integrate that mental health care with the overall healthcare system, and frankly, finally embed mental health index indicators into our electronic medical records so that we don't just have mental health by mental health folks, but we have mental health by your standard healthcare provider, who, by the way, needs to be trained up themselves to be better at delivering mental health care. So technology has really enabled a lot of this integration. On a government side, we have to do more to break down the barriers. Most of the barriers, like with Parity, come in the form of payment. So we talk a good game, and it's nice to see some of the barriers in telemental health lifted. But the biggest barriers now are payment barriers. We want parity, not just in mental health care, but we want payment parity for clinical visits that are virtual. And until we get that really implemented and recognized by all of our major payers, leading off with CMS, we're not going to get the kind of uptake on the value of all of these digital and virtual care platforms that we need. So there needs to be a constant advocacy for this change. And I'm glad to be joined with many of my friends, Chuck Angolia, Tom Insel, a bunch of other friends who are going to be part of this overall conference, who are really pushing to make sure that we bring mental health into the modern era by making sure we reimburse for it. And they'll probably all recognize and identify the statistics that show the value of mental health for the overall reduction in the total cost of care in terms of physical health. But let me just talk briefly about some other areas. We have to, in my view, rectify this arcane kind of holdover of the past of 42 CFR, which separates really the records of those with mental health conditions from the overall EMR. And I am for HIPAA being a solid and sound way of protecting privacy. And I appreciate the historic need to protect the records of people with addiction. But if we're truly going to treat addiction like other illnesses, we've got to treat it like every other illness. And if we have sexually transmitted diseases and all kinds of erectile dysfunction and things that are everybody else would not want to have out there in the public protected by HIPAA, we've got to have addiction and mental health treated in the same way. If we add additional safeguards, while it sounds good in the saying, it's really destructive in the doing. And the reason it's destructive is that it prevents the doctor in the emergency room who is dealing with an unconscious patient who happens to be a person in long-term recovery who just got a major concussion from knowing what kind of interventions to use on that person, because they don't have the full kind of medical record that they are a person who is being treated with medication-assisted treatment, for example. And I think there are numbers of examples each of us in recovery can attest to where we could easily game the current medical system to prescribe all kinds of drugs that are really antithetical to a person living in recovery, but for which the rest of the medical profession has no appreciation for how dangerous they are to people who are fighting in long-term recovery, which, by the way, includes 24 million Americans. So this is not a small population for us to kind of carve out from the EMR. So I think that we have to fix 42 CFR. I'm glad we're having to push out the collaborative care codes so that we can get that real synergy between the rest of medical care and mental health and addiction care. But finally, let me just kind of rattle off a couple of companies I work with in full disclosure that I think really help change this way that we practice medicine. One is Psych Hub. It's a company that kind of curates evidence-based practices and ultimately curates medical providers and all kinds of other providers who are in the field of delivering mental health, including primary care providers and other medical providers, to curate them based upon their expertise in delivering precision medicine for certain diagnoses, and that those expertise come with having a library of evidence-based trainings in that particular area of expertise, so that you have people who are specializing in a certain type of mental illness treat only patients who have that special type of mental illness, so that you can really fine-tune and hone the best evidence-based practices that are going to make a difference for that type of condition, just like we would expect for a type of cancer or other type of medical condition. We see specialists, we see people who have that kind of training for that specialty. So Psych Hub kind of is a match.com for people looking not just for any old provider, but a provider that fits with their diagnosis so that they can treat to the top of their licensure in that area. Dynamic Care, a company that really focuses on using the evidence-based in terms of contingency management, something that most people in addiction treatment really don't know much about, which is tragic because it is perhaps the most sound in the evidence-based treatment of addiction, that reward-based treatment really works for a person with an addiction disease, where the dopamine effect really works if you have contingency management, which means that you reward positive behavior. And you do that through a number of mechanisms. And we need to try to challenge and redirect a person's addicted brain to be a person who is in recovery from being an addicted brain. And a lot of that cognitive behavioral therapy can be shaped and formed through rewarding, doing new behaviors that set up new neural pathways and help a person out of the old stuck default mode. And so Dynamic Care does that while delivering ongoing chronic care management. Paratherapeutics, which does kind of remote cognitive behavioral therapy, marrying kind of software therapy and gamification of therapy, such that you can really engage people in changing their thinking. Even people with severe mental illness like schizophrenia can learn to identify their delusions. Paratherapeutics has a number of different types of modalities in that space. And of course, in this post-COVID world, that kind of remote therapy really counts for a lot. Finally, there are a couple of companies like a Novotel, which really has not just your general, teledoc type of concierge medical physician or provider who you can call up any time of day and see for whatever reason. But a Novotel, and that's all really valuable. A Novotel has a kind of more specialized type of therapy delivering to those who are really kind of mostly in Medicaid space, although it's also worked in other areas. But it really understands how to incorporate telepsychiatry into the rest of the medical record. And as like I said at the very outset, one of the problems we have in mental health is that it's often carved out of the medical record, either by 42 CFR or by the fact that it's not reimbursed, like Parity, or that telehealth is not reimbursed through pay parity. There's all kinds of obstacles, but so Novotel really understands that you got to treat the whole person, that it's not just the addressing the diagnosis, but how that fits into the total care coordination. And there it takes us there. They came out of the community mental health background, so that's their kind of DNA. Quartet is really kind of the traffic cop. They're the air traffic controllers. They really want to intervene where patients might not be diagnosed with a mental illness, but clearly are most likely suffering from an underlying secondary mental health diagnosis of depression, anxiety, but have a primary diagnosis of a cardiovascular disease or diabetes that isn't going to be treated properly if you don't address the secondary diagnoses. And Quartet, their value proposition is let us be proactive and identify people as needing treatment for these illnesses that may not be putting their hand up, but then seamlessly incorporate mental health so that you can reduce the total cost of care. Because we all know if you address depression for those with cardiovascular disease, you drop the risk of secondary heart attacks dramatically 4 times, as well as other indicators. And that is the value proposition of Quartet. They're the kind of air traffic controller. There also is a challenge in people gaining access to the right treatment that's frankly reimbursed by their provider. And so there's a company called We Recover. We Recover basically tries to facilitate when you're in the hospital and you're wondering whether you're going to be able to get into treatment afterwards. Your care provider can basically say, here's your breakdown, here is your insurance, and then push a button and say, here are the facilities within a whatever mile radius or therapy providers that are take your insurance, basically. And that's actually a really significant beginning, because then you can get into, well, what kind of therapy providers do you need? A la back to Psych Hub. But for many folks, they just go wherever they can because they go to where their payer reimburses for that therapy. And, that is a big start, because for many people, they just don't go to therapy because they can't pay for it, as financial obstacles are a huge impediment for people to get into care. So We Recover tries to tease out all of the various codes, what they're diagnosed for, and then they can match that to what their benefits are. So they can match their codes to what their benefits are and make sure that patient goes to where their healthcare can be reimbursed. So in conclusion, I've just kind of gone through just some of the companies that are doing big things in leveraging a connectivity in our healthcare system, especially post-COVID, when, as we know, so much of this care has to be virtual and has to be coordinated. And I just want to say what a great idea it is that you're having this technology summit on mental health. And I'm honored to be on with so many other distinguished folks, and to have a chance to share kind of my views on how this space really is even more important now post-COVID than it ever was before. And I thank you all for being part of it. Thank you, and have a great day.